you, Emily. That reminded me of something that I wanted to mention that isn't on the program today. So those of you who attended the last event of this meeting will remember that we put out a call to individuals with vascular EDS asking them to participate in a research project looking at dental manifestations in vascular EDS. It was a joint project with vascular EDS and classical EDS running across the UK and also in Europe. So just to report back to you on progress from that, because I think it really is always essential when individuals with a condition are involved in research, particularly when they've had to make a trip and spend a long time having their teeth looked at, for instance, that they actually get feedback on that. The study is now complete. The UK has provided 2/3 of the patients for that study, so thank you to everybody. We overperformed. And this is being written up at the moment, and it's anticipated it will be published by the end of the year. Now, we're always asked to keep a secret what's going to be in the publications. So I said to the authors, we're just going to want a tiny bit of something to tell people on Saturday. And they said that overall the feelings are, other than of course the tremendous precautions that we recommend for things like removals of teeth and so on, that there is nothing special to be worried about in the teeth in vascular EDS compared to the rest of the population, so no particular features there, but really what they asked me to say, and this may just sound to you like every dentist and oral hygienist everywhere, but in the people with vascular EDS who had significant dental and gum problems, there were always dental hygiene issues involved. So their message they asked me to give you today was, please, and I think they probably mean individuals with vascular EDS, their families, and all of the staff present today, because it's one of those things that applies to all of us. Please brush your teeth for 2 minutes, twice a day, preferably with an electric toothbrush, and floss at least once a day. So sometimes it takes great academic research to tell us what we should have been doing already, but I think it's also kind of nice to know, just to be reminded that we all need to carry on doing the ordinary things, and they make a difference. And they also said that if you have issues with your gums bleeding, for instance, that's a reminder that you need to do those things that they asked you to do. Next up, I'm very pleased to say that Dr. Oliver Watson, our consultant cardiologist who works with us in the Sheffield EDS service and runs our vascular EDS clinic with us, has come today to talk about the work of the Inherited Cardiac Conditions Clinic with our individuals with vascular EDS. Welcome.
So thank you, Linda. My name's Oliver. I'm one of the cardiologists as part of the team in Sheffield. So moving swiftly on, hopefully to get to your break slightly earlier than planned. Who am I? I'm a cardiologist. I'm trained in Yorkshire. And I'm a specialist in inherited cardiac conditions. That's genetic conditions that can affect the heart. I'm also very involved in imaging, taking pictures of people, mainly the insides of people. And I've been part of the diagnostic service in Sheffield as a cardiologist since 2018. So I did find some photos, which will probably bother the group over there, but mainly so I could do this and fly in Professor Wheeldon in his absence, just because some of you will know well that he does other things as well as run an ICC clinic, and that's occasionally flying planes. So the service, as you'll see, established in 2009, and there are two cardiologists, myself and Professor Wheeldon, and also Naomi, who many of you will know. It's one of our specialist nurses who works mainly in the aortovascular side of the inherited cardiac conditions. And we run regular clinics, joint clinics, with patients with complex EDS and particularly vascular EDS. So why do patients with vascular EDS need a cardiologist? Well, actually, although it's slightly counterintuitive, cardiologists are probably the group of doctors who spend most of their time worrying about vascular health, with the exception of maybe vascular surgeons. And that's because the main blood vessel, the aorta, emerges directly from the main pumping chamber of the heart, and our training involves lots of diseases or problems that can affect the aorta as well as the heart. And also lots of common conditions, simple conditions like blood pressure, are often managed by cardiologists both in the UK and around the world. But importantly for this particular talk, rare conditions, aortovascular conditions, are often managed by genetic cardiologists, along with other specialists. And we're familiar with the medications and the interventions, and that helps us understand the risks and benefits of treatments and interventions in these groups of patients. So, I mean, it is a little bit at risk of teaching your granny to suck eggs a little bit, and you've heard this before today, but it's important to go over all of the things that we do, not just the cardiology bits, the diagnostic service, the really important part about lifestyle advice, patient advocacy, which has also been talked about, management of those associated complications and conditions. But what I'm here mainly to talk about are how we monitor those vascular changes that were mentioned in the previous talk, and how we use medications and why we use those to try and improve outcomes for our patients with vascular EDS. So how do we monitor blood vessels? Well, firstly, it's important to say there are different forms of blood vessels, and what we probably really mean when we talk about blood vessels are arteries. And I know I'm talking to a very educated audience, but it's important to mention that, of course, these are the blood vessels that emerge from the heart and transport oxygenated blood at high pressure from the pump, the left ventricle of the heart, round the body to deliver oxygenated blood to the organs. This is mainly the aorta and its main branches. And the way we can monitor these blood vessels, we've got three main techniques. First of which is ultrasound, and if it's anywhere near the heart, we refer to that as echocardiography. The main one that we use is MRI scanning, and when you're looking at blood vessels, we refer to that as an MRA, magnetic resonance imaging. And then there's also CT scans, and I'll talk a little bit about why we use these different ones, and in order to try and keep people interested, I'll show some pictures. So here's a picture of an echo scan of the main aorta just as it turns the corner at the top of your chest to go down the back of your chest. So this is what's referred to as the arch of the aorta. And I'll just try and put my cursor up here. You can see the blood vessels emerging from that aorta, which will form the neck vessels. But you can see we can only see a little bit of them. And that's because the window, i.e. the bit we can deliver sound waves in, it's quite narrow because it's that bit at the top of the divot at the top of your chest. And we can't just move it anywhere and trace those blood vessels because there's bones in the way, and bones aren't very good with sound waves, they just reflect them back. So it's good for the whole heart, but it's quite difficult to see the smaller vessels and to track them through their sometimes tortuous path. It's challenging to see the whole of the vascular tree. You'd be lying on the couch for hours as people point probes in different places, so it's not a good test for seeing the whole of the blood vessels. But it is sometimes really useful to target a single blood vessel and work out what's going on with the flow inside it. So you can see in the top image, that multicoloured flash is telling us what the blood's doing inside that blood vessel, how fast it's moving, whether it's moving smoothly. And if it moves around all over the place, it suggests things like narrowings. So that's really useful if patients have had problems, for example, in the carotid vessel in the neck. That's easily accessible with an ultrasound, and we can tell things about the lining of the wall or how fast the blood's moving. So moving on to the workhorse of what we do for our patients is MRI imaging. Many of you in this audience will be very familiar with the image on the right, and this is a safe test. It doesn't have any what we refer to as ionizing radiation, so X-rays really. And that means it's ideal for monitoring. But on the other hand, it has some problems. Again, as some of you know, it is quite a narrow tube you've got to climb into. Okay? And that's not suitable for every patient. So there are trade-offs with each of these imaging techniques. It takes a little bit longer to acquire the images, but we can see large vascular territories. So we can almost scan a whole patient's blood vessels in one-ish sitting. I'm not going to go into physics today, might be because I don't fully understand it, but the magnetic fields alter the way the water molecules in your body behave. And in different tissues, those water molecules behave in different ways. That enables us with some very clever maths and physics to say that there are differences between different tissues. Okay? But it is simply magnets, and there is no long-term harm as a result of MRI scanning. We have to give you contrast, and I'll show you why in a second, and that's a dye which has a biologically safe magnetic compound in it that helps us delineate the outside of the blood vessels when that's put on the inside. And this gives us great coverage of the whole body. And that's what we get. Never fails to astound me. On the right, on the left-hand image, that's an image of the carotid part of an MRA. And so you can see it may not project very well, but on my picture you can just about make out the sort of outline of the human shoulders, head, neck and shoulders. So the technique enables us to take the rest of you away and just leave what's left inside the blood vessels because of that dye injection. And we can see all of these blood vessels that supply the brain, and even up as far as into the brain territory itself, until they get very small. And we've probably managed to resolve about 1 millimetre to 2 millimetres with this test. So it's a very good screening test. And on the right-hand side, there's an image of someone's aorta as it emerges out of the heart, here, bends around the corner, and that was the bit I showed you with the echo picture, forms the blood vessels that go up to the neck, and then goes through the body, down past one of the kidneys there, and then splits into either leg. And this is what we get from our MRA scan as our screening. This is what we see. And then we can go through on workstations and measure each of these blood vessels, look for any 3D, so we can move these in 3D real time and look around the blood vessels and look for any abnormalities. So the final imaging test that we can use to look at your blood vessels is a CT. And again, when we're looking at blood vessels, that's referred to as a CT angina. But this uses X-rays. And the technology is not actually hugely different to the X-ray of the chest that you'll all be familiar with, or a bone. But we do a lot of them, and we stick them all together. And if you slice somebody up with X-rays really thinly, X-rays now, you can resolve tiny structures. So the benefit over the MRI scan that I mentioned is the resolution, the size of structures that you can look at. You can look even at things that are even smaller. And here's a slice through someone. And again, you need dye to look at the inside of the blood vessels. It's a slightly different one, but it works in the very same way. And that enables you to light up the inside vessel structure of the body. It's quicker. Anybody who's had a CT scan for any reason also know, if they've had an MRI, that it's a wider tube. It's not as tight when you're in there. It does expose you to a small dose of radiation. So it's not something we want to use repeatedly, but if there's a good reason to use it, then it gives us potentially additional information about things that we might find on MRI scans. And here you can see, running through, the series of slices that we take through, in this case, somebody's heart. And then we can build that back together. In a second, once it's run all the way through, into pictures like that. And that's incredibly detailed information about somebody's chest. And because it's all 3D and each individual pixel represents something about somebody's body, we can just chop away all the bits we're not interested in. And that's an aorta and the branches. And again, you can see all of the smaller branches, so there's even more information from this study. And hopefully, if this plays, I can flip this around. I can move it in real time and look at sections of the blood vessels in incredible detail to work out what's happening in them. So all that's very interesting, but why do we do that? Well, unfortunately, because as highlighted in the previous test, one of the problems with patients with vascular EDS is issues with the blood vessels. So we want to know if there are any abnormalities, those that were mentioned, dissections or aneurysms, because these help us make decisions on medical management or dose titration. It also helps us determine whether further scans are required to plan interventions. And importantly, helps us understand risk so that we can have an effective dialogue with you, the patient, and other specialities about what treatment options we have available, when we should be doing them, and how often we're surveilling patients. And why is that? Well, the important backbone of what we do in the cardiology clinic is to use medical treatments to prevent vascular problems or delay the deterioration or changes in those vascular problems. And what we use are two medications, many of you will be familiar with these. The first of which is a beta blocker, very common in cardiology. There's a sort of vogue in cardiology about considering putting it in the water. It's used for almost every cardiac condition in some way or other, and is an incredibly effective medication for a variety of different conditions. But it mainly reduces the force at which your heart contracts, and partially that's by just reducing the rate. So the heart rate is reduced with beta blockers. That reduces the stress on the wall of the blood vessels. It can slow the heart rate, so we need to be a little bit careful with these medications, and that can mean in some patients people need ECGs and monitoring of heart rhythm. It can also lower the blood pressure, but also that's partially helpful in patients where you're looking to protect blood vessels. The other group of medications we use, angiotensin receptor blockers. These are medications that block hormones produced by the kidney. And they stop the narrowing or the constriction, the tightening up of blood vessels, which lead to high blood pressure. So if you tighten up the blood vessels, it's harder for you to push blood fluid through them, and as a result the blood pressure has to go up, and the work of the heart and the stress on the blood vessels goes up. So one of the effects of these medications is to lower blood pressure, but also importantly we know that these medications from other conditions help stabilise the middle wall, and you saw it in the aorta. All of the arteries have made of three walls, and the middle wall is often susceptible to problems in these genetic conditions, including vascular EDS. And we know from other conditions that these medications are very effective at stabilising that wall and preventing problems and stretching those blood vessels. So it's not quite completely new, but one of the new things we have is increased evidence from the Sheffield group in this publication about the benefits of those medications. And we used 126 patients from 95 families with genetically proven vascular EDS, and looked at the effects of the medication alongside lots of other information about patients with this condition. And the medications are very well tolerated. They do cause your blood pressure to drop. That's the way they work. But that's actually very well tolerated as well. And the withdrawal rates are not very high in the small amount of data that we've got about patients. Our data suggests there may be less vascular events and progression in those patients who are on one or both of the medications that are mentioned here. This is supported also by some French data in a smaller number of patients, again using the same types of medication. So it's the best evidence that we've currently got. And and I think is a big step forward in terms of trying to find evidence and supporting what we believe is the right thing to do for our patients. So in summary, we've got improving technologies to visualise the blood vessels, and these technologies are getting better and better. The resolution of the next generation of CT scanners will be able to see inside you down to less than 0.1 of a millimetre. There's an increasing body of evidence and data to support the medical treatment, monitoring, and some of the other lifestyle aspects that we do and other groups do through their specialist clinics. And the evidence that we have supports the use of that for every patient with a diagnosis of vascular EDS. Thank you very much.
Great, well, we're doing well time-wise. I hope everybody's enjoying themselves so far. Yeah. We're a little early for our tea break, and we've got another action-packed session after the refreshments. I'm particularly excited to hear about the emergency care project that's going to be presented by Juliet Harris and Jackie Fish, and I think something that's very important for all of us. So could I ask everybody to be back in their chairs by 11:25 and ready to go for the next section.